Welcome to the High Risk Pregnancy Training Academy, where ANMs, medical officers and specialists come together to learn about high-risk pregnancy conditions, share experiences and work together to ensure the best health outcomes for mothers and babies. Today we are learning about the identification, treatment and management of the high-risk pregnancy condition, shortness of breath in pregnancy. But first, let's meet our expert trainers.
Hello everyone. I am Dr. Karishma Tharyani, a senior obstetrician and gynecologist practicing in New Delhi. Today we shall be talking about shortness of breath or dyspnea, which is a very common complaint in pregnancy. So much so that up to 50% of pregnant women may complain of difficulty in breathing at some point of time during their pregnancy. Most of the time, this complaint is because of the physiological changes brought about by the pregnancy in the patient's cardiovascular and respiratory systems. However, we also know that pregnancy itself can be a stress factor for the patient's heart and respiratory system. So this difficulty in breathing may be an underlying symptom of an undiagnosed cardiovascular or respiratory illness in the pregnant woman. Therefore, it is very important to understand the different causes of shortness of breath in pregnancy. Today, to help us understand the different causes of shortness of breath, how to diagnose them and how to manage them appropriately, we have with us Dr. Poonam. Dr. Poonam is a senior consultant maternal and fetal health at CFMC New Delhi. Welcome, Dr. Poonam.
Thank you, Dr. Karishma.
So, Dr. Poonam, so many pregnant women present with shortness of breath in pregnancy. What are the causes of this physiological breathlessness?
You're right, about 50% of women do present with shortness of breath, and this increases to almost about 70% when the women goes around 30 weeks or so. Now, the usual causes is the increased flow, which is called as the tidal volume, which increases with gestation and in the pregnancy. And this, with the respiratory rate, which is constant throughout the pregnancy, increases the minute ventilation, which causes further shortness of breath. Now, it's important that we distinguish between the physiological shortness of breath, primarily because of this increased minute ventilation, and also because the baby, as the baby is growing, there is a pressure underneath the diaphragm, which increases the breathlessness in these women. It's important that physiologically it is distinguished from the pathological ways of shortness of breath.
When a woman comes to an ANM with shortness of breath, how should the ANM counsel such a woman?
The ANM has to take a detailed history and understand that there is no underlying causes of the shortness of breath. This could be physiological, as we mentioned earlier on, but it could be also because of a certain causes that is there apart from being physiological. So this includes, if there is any problem with the respiration like asthma, these patients would have wheezing, or if somebody comes with chest pain, predominantly having a breathlessness when the patient is lying down, should alarm the ANM about the cardiac causes of breathlessness. Similarly, if the lady has had loose stools or vomiting, this can also cause metabolic reasons for the shortness of breath. So, having taken a detailed history, and if there is no history which is suggestive of any problems, then it could be managed with the ANM, and the reassurance the patient needs to be given. But should there be any symptoms which the ANM feels that it is not related to the physiological changes in pregnancy, these women need to be referred to the higher centers.
So if the primary level healthcare worker feels that it is physiological breathlessness based on the history and examination findings that you've told us in such details, then how should such a woman be counselled?
These women should be counselled with respect to their diet, ensure that folic acid and iron is taken by the lady, because anemia is one of the most important causes of shortness of breath. Good hydration is needed, and again adequate rest and some exercise is needed. So that should be what the ANM needs to convey to the family and the patient. Obviously, also to discuss about if there is any progressive changes in the problems, then to be referred earlier on than later.
So basically what we should remember is that if a woman has physiological shortness of breath, that is because of pregnancy, in that case she will have shortness of breath only when she is exerting and not during resting. She will have no other cardiac or respiratory symptoms. And in such cases, the woman only needs to be reassured as far as her diet, iron folic acid supplementation and rest is concerned. So Dr. Poonam, if a pregnant woman presents with shortness of breath and on examination the ANM finds abnormal findings like increased respiratory rate or abnormal chest sounds, in that case, what is the ANM supposed to do?
Any history taking suggestive of pathological reasons, which we have enumerated before, or the examination suggests a problem like the respiratory rate being on the higher side above 18, temperature, cough, chest pain, wheezing, all these symptoms, the ANM should refer to the higher centers. In the interim, she can prescribe few medication depending on various symptoms. For example, she can give deriphyllin, she can give a shot of antibiotics in the form of amoxicillin or azithromycin, or at times she can also give furosemide, 40 milligrams, in case she feels the need for it. But a referral to the tertiary center needs to be done at the earliest possible.
So whenever the ANM feels that the patient has presented with pathological shortness of breath, the ANM has to remember that she needs to provide the patient with emergency care in the form of medications, oxygen, etc., counsel her family and refer her immediately to a higher center. Dr. Poonam, if such a patient with suspected pathological shortness of breath presents to a medical officer, how will the medical officer manage?
So the medical officer has to take a detailed history, which has to reflect the reason why the shortness of breath is. And as we enumerated before, the causes being the cardiac, the respiratory or metabolic. And every examination or the investigation will be tuned towards it. So having taken a detailed history and the examination, if there is a need for investigation, routine investigation along with kidney function test, liver function test, or if there's a need for an X-ray with a protection of the abdomen can be done. And a multidisciplinary inputs have to be taken by the cardiologist or the respiratory physicians, depending on what the cause of the whole issue is. And usually intrapartum or labor is not something that needs to be changed. Cesarean is not the reason for it. Only until the time that it becomes too severe, we have to think about a cesarean section. But usually, normal labor can be taken, and cesarean is reserved only for obstetrical indications.
So for the medical officer also, it is important to remember to take a thorough history, do a complete examination so that he or she can come to a differential diagnosis. And then based on the differential diagnosis, the medical officer will provide the patient with emergency care, which may be in the form of nebulization, investigations, injection furosemide, etc. and then refer the patient immediately to a higher center. So Dr. Poonam, when a patient is referred to a tertiary care center, how is she managed there?
So in the tertiary care center, we have various specialists who need to be involved, including the respiratory physicians, the cardiologists, depending on the cause of the problems. If it is a severe case, then such patients are managed in the intensive care unit, and delivery is done in a place where it is all equipped with oxygen and other equipments which may be needed. Pediatricians, anesthetists, and the ICU, especially the critical care specialists, need to be around along with the senior most obstetrician and gynecologist.
Thank you so much, Dr. Poonam, for this insightful session. Today, we have learned that shortness of breath or dyspnea in pregnancy can be physiological in up to 50% of women. But in others, it can also be a sign of an underlying cardiac or respiratory illness. It is very important for a primary level healthcare worker to understand that by means of a detailed history, thorough examination, most of the times we will be able to differentiate between physiological and pathological causes of shortness of breath. All women who present with shortness of breath should ideally be referred to a specialist so that they can be properly evaluated, and if no cause is found, then accordingly reassured. Most women will be managed on outpatient basis. Only a few will require admission and ICU care. To know more about management of shortness of breath in pregnancy, please refer to our protocols. Thank you.
That brings us to the end of this training session about the identification, management, and treatment of shortness of breath in pregnancy. Remember to refer to the high-risk pregnancy management protocol for more details.